Good morning.
Good morning.
How are you?
Okay, and yourself?
I am well. I am well. It's Saturday. We made it another week, huh?
Yes.
Yes, yes. How your week been?
It was pretty quiet. Just,
Okay.
my classes.
Okay.
Mm.
Okay. Yeah. Yeah. I
How
know.
about yours?
Off the chain. It was the end of the semester. So
Oh,
and we have graduation today. So
okay.
yeah, yeah. So it'll be interesting to say the least to see the people and all of the things because our course is 100% virtual, so I don't get to see them often, um, and they're new to me. Period. So I think I just had no, I had two classes with them before they graduated. So yeah, it's gonna be fun.
Yeah.
Yeah,
What time is that today?
two, three, something.
Oh, okay.
I was like, I'm feeling some kind of way because we rented the regalia for us to go back, and I was like, the the stash thing matches what I had, but the color of the gown is not the same. And I'm like, so does everybody just wear a solid black when they come back to for the whatever? Because I'm like, I don't like this. I want my blue. Look, I worked hard and paid hard for that blue, so I want my blue. But we'll see. Because I went and looked for it and pulled it out just in case. Like, I might put my blue on just in case and be different. Y'all know I like to be different. All right. Well, we got some stuff today. Some stuff today. Let's see. Good morning, Crafty Coder. How are you? Welcome,
Good
welcome.
morning.
Our on the street correspondent. Welcome. All right. Well, let's get this party started. Welcome to our Saturday morning tea. Here we brew up the hottest topics in healthcare. We discuss health information, news, education, graduations, the past week and the week ahead, certification tips and entrepreneurship, and really just the revenue cycle at large. And as you come in, don't forget to hit the thumbs up or like button. I'm Clarice Warner, the girl with the pearls, the founder and senior education director of the Professional Reimbursement Network, LLC, where coding education is key. And PRN is a healthcare compliance consultancy located in Cincinnati, Ohio, that specializes in revenue cycle and regulatory compliance in education. Now, let me ask you, do you know what it takes to be a certified marketable medical coder? I have had that conversation more often here recently than I think I've had in a while. Like, really? You don't know? Well, before I introduce my co host, let me share with you information on a free email course on the 5 steps to become a certified marketable medical coder.
Are you interested in medical coding but not sure where to start and scared of wasting time and resources? Let me help you with the right steps to become a certified marketable medical coder. Learn more at bit.ly/5stepscoder.
Hey, hey. If you're interested in getting more information about the 5 steps to become a certified marketable medical coder, check the video description for the link. So, joining me today is my partner in success, my co host, Mr. Jesse, the registered trademark. Put some respect on his name, the coding nurse. Sir, introduce yourself and tell the folks all about you.
Good morning, everybody. My name is Jesse. I live in Philadelphia. I've been in healthcare for decades. In 2014, I left the bedside and I started in risk adjustment coding. Um, During the pandemic in 2020, I created a company, the Coding Nurse LLC, where I help nurses and other people in healthcare with a clinical background transition into the wonderful world of HIM.
And how is that going?
It's coming along.
Okay. Okay. You've been in here for decades. Let them know it. Decades. I love that. I love that. And I love that, even though we've been in this field for decades, we still see uh, uh, room for improvement. We still see uh, things that we can offer and provide to those coming in. We still see even those seasoned ones. Sometimes they don't know. They don't know either. We don't know. And even though we've been here for decades, we're still learning things too. So,
Still.
when they talk about lifelong learning in this career, it's truly lifelong learning. So I love that. I love that. Okay. I didn't mean to steal your thunder, my bad. So before we jump in, let me remind you that you can join in and add to the conversation. Always, you can. So don't be shy. Your opinion matters and is always welcomed here. So use the chat. And if you have a question, please type Q first so we know that it's a question for us and that you're not talking amongst yourselves and we don't miss it. So, for those who are just joining or watching the replay, today we are talking Medicaid coding beyond the diagnosis and what you must know. But first, let's get into our church announcements, shall we? Hey, got you Johnny on the spot. Hey. I like your MLK. I need to change mine. Hey, hey, hey. All right, all right. Really, I didn't have any church announcements. I didn't know if you want to talk about that whistleblower case. Did you want to save that for the meeting after the meeting? Did you want to?
You know, I think we could save it for the meeting after the meeting. But overall, I just think that with the current climate and with all that's going on, I just really think that more people are going to start coming forward and saying, it's bones in the closet over here.
And you need to know.
It's a lot going on behind the scenes at these institutions. It really, really is.
Oh, we like the closets. They full, aren't they? They're probably busting at the seams.
And the only thing that I'm glad of is I'm glad that there are still some HIM professionals who have some integrity.
Yes.
To say that this is not right.
Mm-hmm. Absolutely. Absolutely. And not that, oh, well, they told me and I got to do and da-da-da. Okay. All right. Well, did you have any other church announcements?
The only other church announcement I have is I have a new ICD-10 CM class forming Wednesday, June 18th at 6 p.m. Eastern Time. So to find out more information, mosey on over to thecodingnurse.com or visit my YouTube channel or Instagram, All the Coding Nurse.
Yes, not mosey over. I love it. Mosey on over there. Get. All right. Well, let's get started with today's topic because it was a whole lot going on. Oh, I learned about another musical AI thing that I get to play with. I was like, oh, let me play with that. Let me see what kind of music I can conjure up for our church announcements. Okay. So again, if you're just joining us or watching the replay, welcome. I'm Clarice Warner, the girl with the pearls. And my co-host is the Coding Nurse. And we're here welcoming you to another episode of the Saturday Morning Tea. and we're excited to share today's topic with you all. So I've received some messages, and there's a lot of buzz around Medicare Advantage coding. And we've talked about that extensively. We've talked about the good, the bad, and some of the ugly related to Medicare Advantage coding. But today we're going to shine a light on its often overlooked cousin, Medicaid coding and billing. So did you know? Because I learned a lot in this article. Oh, and let me say, this article was provided by written by Don Carter and Ray Gross. Don Carter is a senior director of health policy and regulatory affairs, and Ray Gross is a manager of coding education. I think they both come from Centauri Health Solutions. So it was a great article, and it's in the description. Anyway, so it got me to digging. Did you know that Medicaid risk adjustment actually predates Medicare Advantage by 7 years? This one took me out. Like, what? Because I remember when this came out and it was all a buzz and all of the things, and didn't know. I didn't know about the cousin, did not know. So while everyone's focusing on Medicare, 91 million Americans rely on Medicaid. So that's over a quarter of our population. And today we're uncovering the unique coding requirements that really can make or break your Medicaid reimbursement. So grab your tea and let's talk about why understanding the connection between diagnosis codes and procedure codes is essential for accurate Medicaid billing. So let's start with some history, because context matters in coding, just like it does in life. When I talk to coders and billers across the country, many are surprised to learn that risk adjustment didn't begin with Medicare Advantage. Like I said, I was also surprised. In fact, Medicaid pioneered risk adjustment all the way back in 1997 in Maryland. There's a full 7 years before Medicare Advantage implemented their program in 2004. Yet somehow, this critical piece of healthcare reimbursement history isn't widely discussed in our professional circles. So why does this matter to us as coding professionals? Well, because it shows that Medicaid has been refining its approach to risk adjustment for over 25 years now. When we understand this long evolution, we better appreciate why Medicaid's approach differs from what we might be accustomed to with Medicare Advantage. Today, the numbers are staggering. 46 states currently have contracts with some form of managed care, and 75% of all Medicaid beneficiaries are enrolled in managed care programs. Of those states using managed care, 38 contract specifically with risk-based MCOs or managed care organizations. The bottom line, if you're coding for Medicaid patients, you're likely participating in a risk adjustment model with a long established history, not a recent innovation. Understanding this history helps us appreciate why accurate coding is so crucial for this population. Now, here's where things get really interesting for us as coding professionals. While Medicare Advantage uses a single risk model, the CMS HC, or Centers for Medicare and Medicaid Services hierarchical conditional category model, Medicaid employs several different models across states. Medicaid has to be, they have to do their own thing in their own state. We see it on every level. The most prevalent model is the CDPS, which stands for the Chronic Illness and Disability Payment System. This model is used by 33 of the 38 states that implement risk adjustment. So if you're working across multiple states or for a large healthcare system with a multi-state presence, you need to be aware that the risk adjustment model might differ from one state to another. So think about the complexity for a moment. If you're coding for Medicare Advantage, you have one model nationwide. But with Medicaid, you potentially need to understand multiple models depending on which state you serve. And why does this matter? Well, because different models may prioritize different conditions or use different methodologies to group diagnoses. Now, while all of these models perform similarly in terms of overall predictive accuracy, understanding which model your state uses will help you focus your coding, education, and quality initiatives on the right area. So, my first takeaway for you: know which Medicaid risk adjustment model your state uses, and make sure your coding team understands its specific requirements. Again, isn't a one size fits all program. Okay. And Mr. Jesse, you know the drill. The CDPS framework. So let's dive a little deeper into that. Again, chronic illness and disability payment system. And since 33 of the 38 adjusting states use this model, there's a good chance you're working with it. In its current version, the CDPS model has 52 categories within 19 major categories. These major categories correspond to body systems or types of disease. The model focuses particularly on conditions that are more common among individuals with disabilities, which aligns with the Medicaid's mission to serve vulnerable populations. So when we talk about these categories, think about how ICD-10 codes get mapped to them. For example, when you code for a patient with a chronic respiratory condition, that code gets assigned to a specific CDPS category, which then impacts the risk score and ultimately reimbursement. Well, what's fascinating about the CDPS is that it was designed specifically with the Medicaid population in mind. So, unlike other risk adjustment models that might have been adapted from commercial insurance, CDPS was built from the ground up to address the unique health needs and utilization patterns of Medicaid beneficiaries. So, for those of us in coding and revenue cycle, this means we need to understand not just how to assign accurate ICD-10 codes, but also how these codes map to CDPS categories. And that mapping might differ from how the same codes map in other risk adjustment models. So, a second takeaway: familiarize yourself with the CDPS categories relevant to your patient population and prioritize complete and accurate coding for conditions that fall into these categories. This understanding helps ensure your organization receives appropriate reimbursement for the care provided to these often complex patients. Also, here's another area where Medicaid coding differs significantly from Medicare Advantage. And its difference that can have serious financial implications if it's overlooked. So, unlike Medicare Advantage, where the primary focus is on the diagnosis codes themselves, Medicaid coding revolves around the correlation between your HCPCS and CPT codes and ICD-10 diagnosis codes. So let me break that down. We all know HCPCS stands for Healthcare Common Procedural Coding System, and CPT stands for Current Procedural Terminology. Well, these code sets describes the services and procedures provided to patients. And when we talk about annual wellness visits, and evaluation and management codes, we're referring to the specific HCPCS or CPT codes that represent these services. So in Medicaid, there's a critical focus on ensuring that the diagnosis codes reported are appropriate for the age of the beneficiary, the type of service being provided, again, as indicated with your HCPCS or CPT code. For example, when coding for a pediatric wellness visit, the diagnosis code should be age appropriate and aligned with the preventive service being provided. Reporting adult specific conditions for a pediatric patient would raise red flags. Another crucial aspect of understanding when it's appropriate to capture codes that represent both illness and wellness, and when to use modifier 25. For those who might be newer to coding, modifier 25 indicates that a significant, separately identifiable evaluation and management service was performed in addition to a procedure or service. So misuse of modifier 25, or the improper correlation between the diagnosis and procedure codes, presents a significant risk of overcoding, which can lead to overpayments, and potentially impact quality measures and incentives. So, my third takeaway would be pay special attention to the relationship between the services provided and the conditions reported. Ensure this relationship is logical, age appropriate, and supports medical necessity. Regular audits of this correlation can help identify and address potential coding issues before they become compliance concerns. Let me give you a concrete example of what I'm talking about with this correlation between diagnosis and procedures. So imagine you're coding a pediatric well child visit for a 4-year-old. The provider performs the routine preventive visit, CPT code 99382 for a new patient or 99392 for an established patient. During this visit, they should report the Z00129 encounter for routine child health examination without abnormal findings as the primary diagnosis. Now, what if during this well child visit, the provider also identifies and manages the child's asthma? In this case, you would still report the preventive service code, but you would also report an appropriate evaluation and management code with modifier 25 to indicate the separately identifiable service for the asthma management. The diagnosis coding would now include both the Z code for the well child visit and ICD-10 code for the asthma. Without that modifier 25, reporting both the preventive service and an illness diagnosis could trigger auditing flags. So with the modifier 25 properly applied, you're accurately representing the full scope of care provided during that encounter. Now, again, this is where Medicaid coding differs so significantly from Medicare Advantage coding. In Medicare Advantage, your focus might simply be on capturing the asthma diagnosis for risk adjustment purposes. In Medicaid, you need to ensure the proper correlation between all of the services provided and the conditions reported with appropriate modifiers when multiple services are rendered. Let's talk about money and quality, because in healthcare, these two are increasingly intertwined, especially in Medicaid. Most states accurately or actively track the quality of their Medicaid programs, and over 75% of states with MCOs reported using at least one financial incentive to encourage better care. These incentives often focus on critical areas like mental health, long-term illness care, and outcomes related to pregnancy and birth. What does this mean for coding professionals? Well, your work directly impacts not just reimbursement, but also quality measures that determine financial incentives and penalties. Accurate coding ensures that conditions are properly documented and reported. Quality measures accurately reflect the care provided. Your organization receives appropriate financial incentives for quality performance. But here's the challenge. Most states do not make detailed information about individual health plan performance publicly available. This means it's difficult for Medicaid recipients and others to compare how different plans are performing in areas like access and quality. As coding professionals, we have a responsibility to ensure that our work contributes to transparency and accuracy in quality reporting, even if that reporting isn't always publicly accessible. So my fourth takeaway, understand which quality measures your state prioritizes for Medicaid and ensure your coding practices support accurate reporting on these measures. This awareness can help your organization optimize both reimbursement and quality-based incentives.
I just wanted to jump in just to
Jump
say
on
that, CDPS hardly ever gets talked about.
Yes, sir.
You don't hear, like, not even in, like, AAPC, they talk all day long about risk adjustment, but you never, I can't remember ever reading any kind of coding journal where they referenced it. And I know, like, when I started at Inovaline, we used to do CDPS reviews, and I hated them because they were beyond full code capture. I mean, no, because normally in coding, if you have a diagnosis and you have symptoms that go along with that diagnosis, you don't code it. But with them, when I tell you, you code everything, every symptom, everything.
Hmm.
If they reported a cough and a runny nose, you had to, in addition to those ICD-10 CM codes, you had
Hmm.
to code cough and runny nose.
Hmm.
And you would have an insane amount of codes doing these reviews. I mean, because literally, like every symptom, every you had to. I,
Did
but
they have
what
productivity standards at the time?
they did,
Oh my
it
God.
it was either one chart per hour, or I think it was like 50 pages per hour.
Okay.
And they was still like well, that was the goal, but they would never get to one, because
Wow.
it's impossible, because just like with risk adjustment, you don't know what size chart you're going to get.
Yep.
And you have some people who go to the doctor for everything.
Hmm.
And imagine having to do that for like a whole year with somebody.
Yes.
It's but when you think about the intention of it, it makes sense.
Hmm.
But it's very tedious to do. I don't know if they have since changed how they do it, but I know we used to hate them. Like when we got to do regular HCC, that was like Candyland.
Wow. That's what's up. I'm glad you brought that, personal experience using this model, because, like I said, this was all new, all new. Okay, so let's talk about one of the most important emerging areas in medical coding, and that's the social determinants of health, or SDOH. So in 2024, most states using MCOs reported using their contracts to promote at least one strategy to address social factors that impact health. So states can also use these contracts to help reduce differences in health outcomes among various groups. This is where Z codes become particularly important in Medicaid coding. Z codes in the ICD-10 can capture social factors like housing instability, food insecurity, transportation challenges, and other non-medical factors that significantly impact health outcomes. So next generation risk adjustment models are being developed that include not just clinical data, but also social risk factors, particularly important for programs serving diverse populations. These models provide better estimates of the interactive effects of behavioral and physical health issues. So, for many Medicaid beneficiaries, social factors may have as much impact on their health as medical conditions. Ensuring these factors are properly documented and coded is essential for comprehensive patient care, appropriate risk adjustment, and targeted social service interventions. So, my next takeaway: ensure that capture of social determinants of health related Z codes is incorporated into your workflows. The Medicaid population has a high prevalence of these conditions that represent social risk factors, and proper coding of these factors will become increasingly important as risk adjustment models evolve. Now, let's wrap this up by talking about the sheer scale and impact of Medicaid coding. Sometimes we get so focused on the technical aspects that we lose sight of just how many people are affected by our work. Again, Medicaid pays for nearly half of US births. Let that sink in for a minute. Nearly half of all babies born in this country have their delivery and initial care covered by Medicaid. Beyond maternal and infant care, Medicaid covers over 91 million lives out of the current US population of 347 million people. That's more than 1 in 4 Americans who rely on this program for their health care. With numbers this large, even small coding errors can have massive financial implications. Again, overcoding or undercoding doesn't just affect your organization's bottom line, it affects program integrity, beneficiary access to care, and the sustainability of the Medicaid program itself. So, my final takeaway, remember the human impact of your coding work. When you code accurately for Medicaid beneficiaries, you're helping ensure that vulnerable populations receive appropriate care, that healthcare providers are fairly compensated for that care, and that the Medicaid program remains financially viable to serve future generations. Put a pin right there. Okay. So I see it on your face. I see the whole look. So before we wrap up, again, let's review those key takeaways. So know which Medicaid risk adjustment model your state uses and make sure your coding team understands its specific requirements. Familiarize yourself with the CDPS categories relevant to your patient population and prioritize complete and accurate coding for conditions that fall into these categories. Pay special attention to the relationship between the services provided and the conditions reported, and ensure that this relationship is logical, age appropriate, and supports medical necessity. Understand which quality measures your state prioritizes for Medicaid and ensure your coding practices support accurate reporting on these measures. Ensure the capture of SDOH related Z codes is incorporated into your workflows, as the Medicaid population has a high prevalence of social risk factors. And remember the human impact of your coding work. Accurate coding supports both financial sustainability and quality care for vulnerable population. And here's one bonus takeaway. If you're partnering with vendors to perform coding work for Medicaid, choose a partner with specific experience in Medicaid. Although ICD-10 and HCPCS coding guidelines are universal, Medicaid coding has some unique aspects that vendors focus on other lines of business might miss. So that's real clear and real important. Okay. Mr. Jesse, you have any other?
I just wanted to touch on these social determinants of health, because they've been around for a while. And you were talking about, I remember when you were in school in your grad program, you started talking about it more, and I'm like, now is it becoming a mainstream issue, and it's because now they have appropriately tied it to reimbursement. And it's a shame that everything in this country is tied to money, but now, but it should have been a while ago, and I think that's the only reason why it's even taken seriously now. But if you think about it, it's perfect. That it's common sense that somebody's living situation can affect their health, or somebody's ability or access to nutritious food, or access to transportation, all of that. But it's a shame that it had to be, once they, made certain SDOHs, CCs, and HCC categories. Now it's getting
Now they
its rightful
scrambling to
place.
make sure they put the
Right.
information on there, and years ago, before all of this, it was just, oh, they're non-compliant, but no one wanted to understand why they may be non-compliant. And this clearly ties those things together. If you know what's happening outside of their medical conditions and the social determinants of what's happening, then there's a direct impact. And why people didn't think that was important before, I don't know. But but now, like you said, because some coins is tied to it. Oh yes, we got to make sure we capture all of this stuff.
And a lot also, there is, I don't think it's a bias, but there's a certain framework around how people think based on where you live, because most people, the people who've grown up, especially in like the Northeast, and even though Ohio isn't Ohio considered the Midwest, but I still think it's kind of Northeast. But
no, we still consider Midwest.
but So when you grow up in urban areas, you have access to almost everything.
Mhm.
And then you have to keep in mind that there are huge swaths of this country that is not like, it's very rural.
Yes.
And so somebody, like they can't call paratransit, but that's what they call it here in Philly. You can't call paratransit to come and take you to the doctor's office, or if you do, you have to call like a month ahead of time to set it up because they got to come down some dirt road to get you. That is just, I don't know. The social determinants of health have really been, especially now that you see them and
Mhm.
as a focus, like it really, really brings to mind, especially when I was doing reviews in other parts of the country. Like
Mhm.
you really see how it really does affect people.
And I think just some of this in more recent years tracking has has provided more access, and I'm thinking about like the transportation piece to your point, because I've noticed there have been an explosion of transportation organizations or folks creating non-medical or medical transportation or whatever it is that they
Mhm.
provide to get people like to and from doctor's appointments and that kind of thing. And so, um, again, because you see or have documented or you have the data on the need, now you know how to address the need. And I think that it has been just a wonderful um, out, a wonderful way that they've taken that data and said, oh, okay, here, this is what has been identified, and this is the solution to that. So again, hopefully looking at the other data that is being captured, that should be captured, other programs or other solutions can be put in play to assist in those areas too. I mean, we all know there's several food deserts in our country, and hopefully, seeing the data and how that this impacts people's health and wellness will then maybe push the need for getting rid of these deserts or minimizing these deserts as much as possible. So hopefully that will work as well.
And it's so interesting that when you were talking about data, like I am really, really enjoying my data analytics class because, well, first of all, like I am developing way more of an appreciation for Excel than I ever had
Okay.
because I didn't like it. But
Yes, because you kept saying, don't use
I,
this, not that.
but what I am, but getting, tying it directly to data, it is amazing how you can use other platforms, but in Excel, how you can, like we were talking about cleaning,
Mhm,
data and how they do it and how you find the outliers and what do you
mhm,
want to do with outliers and how those outlier either, the how outliers period
mhm,
can affect your data distribution.
mhm,
It's really interesting. And you know what, and my whole takeaway, as I mean, every class I'm sitting there like, why aren't more coders involved in this? Because you have people who are manipulating these numbers, but it doesn't, well, this is information, but it really doesn't, even though they can come up with they can show you, but are they really explaining it to these stakeholders accurately?
yeah,
Even though they have it there, like, is the message really getting across what it really means?
yes. And
And
and while we know in most instances, we see the information, we know because we're in the weeds, we understand. To your point is making sure those who are removed from it, how do you get that inform how do you convey that information to them, so they can say, "Oh," because we keep saying it and maybe that's kind of the disconnect, like, why are they not understanding? Well, maybe it's in the message.
And,
um,
al- and also in the data, because I just want to know, are they really, really drilling down? Like, I don't like, you can say diabetes, but we know diabetes is vast.
mhm,
Like, what types of diabetes are the most prevalent? What are the most prevalent complications?
mhm.
I mean, I'm sure that there's some overall data that you could look at to figure that out, but I just don't think like on a on a on a micro level, a lot of these medium sized to smaller institutions really, really understand that, because I don't know whether if they have the people who have that know-how to put it all together like that.
Mhm. Well, I'll be teaching. It's a data analysis class, but it's mostly tied to statistics um, next semester. So I think our text is from Dr. White, who did the data thing that you talk about at AHIMA. So I'm real interested in what this is going to look like. I was strumming through the book the other day, like, oh, okay, all right, but it's at a very introductory level for. We'll eventually ratchet up, but it's at an introductory level for the students. So it's going to be interesting to see. I'll probably be picking your brain too. From your data perspective, because you deep in the trenches.
And then what I also didn't realize, I'm like, oh, that's a game changer, because you know how like we use Excel, we use spreadsheets all the time.
Everything I tell them
But
all the time. They had to take a
but
whole Excel class in our program.
but here's the thing. The next step of that is you don't use the regular spreadsheet. You convert the spreadsheet to a table.
Mhm.
And then from the table, you could, because there are things you can do in Excel with a table that you can do with the flat file.
Okay.
I'm like, oh,
You'd be like, ding, 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 ding. Light bulbs be coming
yes.
out. Like, wait a minute, hold up. Be like, say more.
Yeah, because we were in class and I'm like, wait a minute, I'm missing a step here. And somebody asked a question and he was like, oh, no, no, no. So, like, because a lot of times, especially when you go to download data
Mm.
from other sources, it's like a CSV file. So you
Okay.
take the CSV, then you turn it into a spread and an Excel worksheet. Then from there, or workbook, then from there, you need to convert it to a table. So you can, and I'm like, and I've seen them, but not really playing it, not even really putting two and two together. Oh, that's a table versus a regular spreadsheet. And I just thought they just put filters on everything, but that's what the table
Mm.
does.
Okay.
It basically filters every row for you. And then when you go to do certain manipulations, it's just easier. And that's especially when you want to create like slices and dicers. I'm like,
Right, because then you get to preserve your data and then kind of manipulate or play around with the output into the table.
Okay, all right. I see you, Excel.
You done gave a cousin a bad name. Here we go.
Uh-huh. I mean, then we got into like um the the bell curve and standard deviations. I mean,
Mhm.
he's really getting into it. I'm like, but I'm really seeing how, and I'm like, but like somebody who really, really, really understands what the codes mean and what these diseases mean can really, really like help these organizations.
Absolutely. Absolutely. Yeah. Oh, you having fun.
Uh,
You are having fun. All right. So now I love how engaged we normally are here at the Saturday morning tea. And I know you may have some questions after today's episode. I know I do. Indeed. Well, let me address some of your thought-provoking questions that I anticipate might be on your mind, which was actually on my mind. Okay, so How might the diversity of these Medicaid risk adjustment models across states create compliance challenges for providers and health systems operating in multiple states? So I know working in the past at a large healthcare organization that was across multiple states, it was a doozy. um, and it created a lot of headaches because there were things you had to know. So imagine you're a coding manager for a health system with facilities in 5 different states, for example. And then each state might use a different risk adjustment model with different priorities. So state A might use the CDPS model, which has those 52 categories within 19 major categories, as we discussed. Well, state B might use the Medicaid RX model, which incorporates pharmacy data. And then state C might use a completely different approach, or there may be one that uses a combination of the two. So this diversity creates several compliance challenges because your coding education has to be state specific. How about that? You can't train all your coders the same way across your organization. Your internal auditing processes need to account for these differences, and what's considered appropriate in one state might be flagged as a potential issue in another state. Your EHR and coding software needs to be configured differently for each state, which creates IT and workflow complications. And lastly, reporting and analytics become much more complex when you're trying to compare performance across states using different models. So the solution, many multi-state organizations are creating state-specific coding teams or specialists who become experts in their particular state's models. Others are investing in advanced software that can apply different rule sets based on the patient's state of coverage. And still others are partnering with vendors who have specific expertise in each state's Medicaid program. Again, whatever approach that your organization may take, documentation is key. So make sure your policies and procedures clearly document which model applies to which patients and how your organization addresses these differences in daily operations. Next question addresses a growing area of importance. Again, how can healthcare organizations better incorporate the SDOH coding into their workflows when many EHR systems aren't optimized for capturing this information? So we talked about how social determinants of health are critical factors for Medicaid populations. But you're right, many EHR systems weren't initially designed with SDOH coding in mind. And so this creates a real challenge for organizations trying to capture this important information. Here are some approaches that folks have mentioned that they have done. Update your intake forms to specifically ask about social factors like housing stability, food insecurity, transportation access, and safety concerns. Having patients self-report this information creates the documentation needed to support SDOH coding. Second, create structured templates within your EHR that prompt providers to address key SDOH factors. These templates can include checkboxes or drop-down menus for common social factors, making documentation more consistent. Train non-physician staff to identify and document social determinants of health factors. Medical assistants, social workers, case managers, and community health workers often have more extensive conversation with patients about their social needs than physicians do during brief clinical encounters. Consider implementing discrete fields in your EHR specifically for SDOH factors. Even if these aren't built into your system by default, many EHRs allow for custom fields that can be used to capture this information in a structured way. And finally, create coding tip sheets that link common patient situations to appropriate Z codes. Many providers and coders aren't familiar with the full range of Z codes, even though coders should be available for social factors.
Should be.
So these resources can be incredibly valuable. The organizations that do this best often form interdisciplinary teams with representation from clinical, coding, social work, and IT departments to develop comprehensive approaches to SDOH documentation and coding. Moving on to our third question, with the evolution towards next generation models incorporating EHR clinical data, how should healthcare organizations prepare their coding teams for this transition? This is a fascinating area of development and risk adjustment. So next generation models are beginning to incorporate clinical data beyond just diagnosis codes, things like lab values, vital signs, and functional assessment. So to prepare for this transition, healthcare organizations should consider several stages. First, the knowledge gap between coding teams and clinical informatics. Traditionally, these departments have operated somewhat in a silo, but with clinical data becoming part of risk adjustment, they need to collaborate closely. Cross-training opportunities can help coding professionals understand clinical data elements and help informatics teams understand coding requirements. Audit the quality and completeness of your EHR clinical data. Before this data can be used for risk adjustment, you need to ensure it's accurate and consistently documented. Many organizations are surprised to discover significant variability in how clinical data is recorded. Don't be surprised. Audit your data. Develop new quality metrics specifically for clinical data elements that will impact risk adjustment. Just as we audit coding accuracy, we need to audit the accuracy of vital signs, lab values, and other clinical data. Invest in tools that can analyze unstructured clinical data. Much of the valuable information in EHR is in clinical notes rather than discrete fields. And so your natural language processing, you know what that is, and other AI technologies can help extract this information for risk adjustment purposes. And finally, stay informed about model development in your state. Again, each state will likely adopt next generation models on different timelines and with that different specifications. Maintaining close communication with your state Medicaid agency will help you anticipate and prepare for those changes. And the organizations that will navigate this transition most successfully are those that view it not just a coding challenge, but as an opportunity to integrate clinical and financial data in ways that better represent patient complexity. And then our final question, given that most states don't make detailed information about individual health plan performance publicly available, how can coding professionals help their organizations stand out in quality requirements? Again, this is an important question because it touches on both the technical aspects of coding and the strategic positioning of your organization. So while detailed plan-specific quality measurement may not be publicly available, there are several ways coding professionals can contribute to organizational excellence. Again, first, become experts in your state quality incentive programs. Understand exactly which measures are tied to financial incentives and how they're calculated. This knowledge can help you prioritize coding accuracy for the diagnoses and services that most impact these measures. Second, implement preemptive analytics to monitor your own quality performance. Don't just wait for the state or MCOs to tell you how you're performing. Develop internal dashboards that track your performance on key quality metrics in real time. Develop partnerships with your contracted MCOs. While the state may not publish detailed performance data, individual MCOs often share plan-specific performance data with their contracted providers. So building strong relationships with the MCO representatives can give you access to this valuable information. Leverage HEDIS and other standardized quality measures. Even if your state uses custom measures, many are based on or similar to HEDIS measures. So by excelling on these industry standard metrics, you position your organization for success across multiple quality programs. And finally, document and quantify the impact of your coding accuracy initiatives on quality measures. Being able to demonstrate that improved coding processes led to measurable improvements in quality scores can help position your coding team as strategic partners in organizational success. When I tell you that's a functional resume statement right there, that's a functional resume statement right there. So again, by taking these steps, coding professionals can help their organizations not just comply with quality measurement requirements, but excel in ways that drive better patient outcomes and financial performance, even without public reporting of the detailed results. So these questions really highlight the complexity and importance of Medicaid coding. And it's not just about getting paid correctly, even though that's important. It's about ensuring quality care for vulnerable populations, supporting accurate quality measurement, and preparing for future developments and risk adjustment. Again, if you're working in a Medicaid heavy environment, I encourage you to dig deeper into these areas. And especially if you're working with pediatrics, um, the American Academy of Pediatrics have resources. They have educational materials on preventive medicine coding that can be invaluable if you're working in that area. And then remember, in medical coding, context matters as much as content. So understanding, and I say this all the time, understanding the why behind coding requirements helps us apply them more effectively and adapt to the ever evolving landscape of healthcare reimbursement. I would love to hear from you. So let me know what challenges you may be facing with Medicaid coding, or is this all new? Or are you hitting like, wait a minute, I ain't never heard this before. What is going on? What is all of that? So feel free to drop your questions in the comments below and let's continue the conversation. And I'll be looking for some of the things that you say, and we may even address them in a future episode. Again, this is why I love our Saturday morning tea community, because we learn from each other every single week. At least I know I'm learning a whole lot in just this. Go ahead, Mr. Jesse. I see you want to say.
And I mean that's a perfect point. But I always go back to what our organization should be doing, like what AHIMA and AAPC should be doing for the industry. And these are the kind of articles that I would like to see in these publications, and you just don't. Right? It's just like they're letting they have let whole swaths of employment opportunities just like slip right by them without even mentioning to their members, well, hey, this is where this is an area where you could really make some impact.
Mm-hmm.
And it's a little different than daily production coding, but that daily production coding skill can be used in a new way.
Mm-hmm.
And it's just, that's why I'm just glad that we have these kinds of conversations. And it's just, like I know for me personally, as much value as we give, like we should have way, way, way more followers. But it's the truth. But it is what it is. But
well, we don't deal in drama usually. And drama attracts attention and followers and all of the things. And we just give some good quality information that people need, especially as you are looking at the future of our profession. And when we're setting folks up to be proactive versus reactive, because a lot of people are just like, oh my God, when it gets here, what I'm supposed to do. No, you should have had those conversations now, years before everything actually hits the fan. But folks just caught up in what they caught up in, and we just do what we do, right?
there you go.
All right, well, next week we will definitely be discussing another hot topic with more information on health information. So you won't want to miss that. All right. So let's wrap up here. So thirsty for perspectives on the healthcare revenue cycle? By becoming one of the PRN T-Sippers, you'll join a community of sharp minds who savor the complexity of healthcare revenue cycle. Why sip alone when you can steep in knowledge together? Come, let's spill the tea on industry insights. Here's what you can expect as a value member of the T-Sippers. Exclusive healthcare insights. Gain access to in-depth articles, webinars, and resources covering the latest healthcare trends, compliance updates, and revenue cycle best practices. Early access. Be the first to receive expert insights and guides, ensuring you stay ahead in the ever-evolving healthcare industry. personalized support, enjoy direct access to our team of experts for guidance on medical coding, compliance issues, and revenue cycle management. We're here to answer your questions and support your professional growth. And my favorite, community connection. Join a private community of healthcare professionals where you can network, share experiences, and collaborate on finding solutions to common challenges. So by supporting us, you're not only advancing your healthcare knowledge and career, but also contributing to the success of the Professional Reimbursement Network, LLC, a resource that empowers healthcare professionals like you to thrive in their roles, goals, and dreams. So thank you for considering becoming a member of the PRNT Sippers. And for the cost of about 2 cups of tea a month, you can join the community. Check out the link in the description of the video. You can also go to bit.ly, the PRNT Sippers, for more information. Your support means the world to us, and we look forward to helping you excel in the world of health information and healthcare revenue cycle. All right, y'all. Well, thank you so much again for joining us on the Saturday morning tea. Let me ask, was the tea spilled today? Put your tea cups in the chat if you felt the tea was spilled. Now, before we sign off, we just want to, as Mr. Jesse said, we don't have enough followers. We're giving you information. We're providing all of this timely information, but folks are not following. So if you found this episode helpful, don't keep it to yourself. Share the knowledge, share the information with your colleagues by hitting that share button. And why not subscribe to our channels while you are at it? That way you'll never miss a drop of health information, compliance, revenue cycle, and medical coding tea. Again, if you have additional thoughts or questions or experiences that you want to share about today's topic, I see y'all with y'all teacups. Make sure that you drop the information in our comments. We love to hear from you, and we can keep this conversation going. So again, if you enjoyed the episode, let us know. Again, that engagement helps more healthcare professionals find our content. And then don't forget to check out the Coding Nurse channel on YouTube and the Coding Nurse on Instagram.
Yeah.
And you said something else on everything. Mm. Put some respect on his name, on everything. So remember, at the Saturday morning tea, we're all about building a community of savvy, informed healthcare professionals. So again, do what you got to do. Like, share, subscribe, and comment, and let's grow our community together. Okay. Mr. Jesse, do you have any closing thoughts?
No, this was a very interesting session, which they all are, because CDPS just doesn't get talked about enough. And it's like you always said, it's the why. Like, why is this what it is, and how does this impact what I do? Right.
And with our current climate, government climate, you never know how the wind is going to blow. So being abreast and knowing all of the nuances related to Medicaid and states and government is also important as well. So we have a responsibility from the healthcare side, and we have a responsibility even as consumers to be knowledgeable on such things. So we're giving it to you straight, no chaser. All right. Well, this has been a great session today for you PRNT sippers. We'll see you at 10:15 a.m. Eastern Standard Time. And remember, be safe, be kind, and don't wish for it, work for it. I hope you all have a great weekend. Happy Mother's Day to all the mothers out there. Enjoy yourselves, enjoy your day. And we will see you next time. All right. Take care.
Bye-bye.
Bye-bye.